నువ్వు జాయిన్ అయ్యావా?
Good afternoon. Namaskaram everyone. Good afternoon and welcome to today's IAP Twin Cities branch clinical meeting. At the outset, I convey warm regards on behalf of IAP Twin Cities Executive Board. We welcome all the participants here and we request you all to please register for the IAP PATS-IAP Annual Pedicon 2022. This is from December 9th to 11th. It promises to be a very engaging and a very exciting annual conference. It is going to be a social, cultural, academics, along with lots of sports and entertainment. So please register in case you have not yet registered. We have a lot of workshops, also 2 sports days on 27th November and 4th December, along with the cultural event. So please register for the conference at the earliest. This month, we also have 2 central IAP workshops, one on learning disabilities, which will be on the 26th of November on the Saturday, and pediatric endocrinology central IAP workshop on 27th of November. So please be available and participate in large numbers in the central IAP workshops. I'll now request our President IAP Twin Cities branch, Dr. Sunkoch Bhaskar sir, to please give his inaugural remarks, and then to hand over to Dr. K.V. Rao, who will be conducting the proceedings today. Over to Dr. Bhaskar sir.
Thank you, Dr. Sri Krishna. Thank you. And distinguished experts, Dr. Soren, Dr. Pritish Nagar, and as well the distinguished presenters from the 4 institutes, and as well my dear participants. I could acknowledge the presence of some of our senior members, Dr. Surendranath, Dr. Thudum Anand, Dr. Srinivas Kalyan, and few more seniors are there. I welcome you all to this 11th IAP TCB virtual clinical meeting. We are very lucky and proud to say that we could do 11 programs of this kind until this month, and next month will be our last one. We could do all these purely because of your support. There are so many pediatric institutes are there in Hyderabad. So we are getting a plethora of interesting cases to be presented in clinical meetings. And they are really so useful, not only for the postgraduate students, but as well to the practitioners. Today we have 4 interesting clinical cases from Apollo, from Paramita, from Nilofer, and from Shalini. My special thanks to Dr. Bhuvneshwar Rao from Paramita, Dr. Srinivas Kalyan from Nilofer, Dr. Rajna Wali from Shalini, and as well Dr. Sri Krishna from Apollo. Lastly, we appreciate the presence of participants. With their participation and encouragement, we could do all these academic activities. Had there been no participants, no point of getting interesting cases, no point of organizing the meetings. So it's all a mutual symbiosis like thing. Organizers, faculty members, and as well the participants. With these few remarks, I would like to remind about our IAP Twin Cities branch with Telangana State Pedicon, which is going to be held on 9th, 10th, and 11th of December. 9th, we have pre-conference workshops. 10th and 11th, we had planned to have a conference mainly focusing on the faculty members which were not given an opportunity earlier, who were not exposed despite their great talent and strength. So with these few words, I wish we'll have a great learning experience from this, and as well great knowledge sharing. And now I request Dr. K.V. Rao, our IAP Twin Cities branch executive member, will conduct the program of this PG interesting IAP TCB clinical meeting. Over to you, Dr. K.V. Rao.
Good afternoon, everybody. Thank you, Dr. Bhaskar. Thank you, Dr. RSC. Thank you, IAP TCP, for giving me this opportunity to conduct this. Today we have 4 interesting cases. The first case is by Shalini Hospital, a case of neonatal encephalitis by Dr. Aswad and Dr. Pratya Wali. Dr. Aswad is there?
Yes.
Hello. Hello, good afternoon.
Yeah. Good afternoon. Good afternoon.
I'm sharing the screen.
Yeah, please.
Before you begin the presentation, welcome Dr. Pritesh Nagar and Dr. Chopai Soren. Both of them would be discussing the case. Feel free to please interrupt the presenter whenever required. Over to you.
Hello, good afternoon, everyone. I'm Dr. Aswad from Shalini Hospital. Today I will be presenting a rare case of neonatal encephalitis. Here are the patient details. The name of the patient was Master P. Anish, presented at 28 days of age with a weight of 4.2 kgs. The date of admission was 16/10/2022 and the baby was discharged on 24/10/2022. Here are the presenting complaints. 28 days male child of 4.2 kgs was brought with complaints of cough and cold since 3 days. And there was high grade fever for 1 day. There was excessive cry and irritability since 1 day. There was 1 episode of seizure at presentation. History in brief, the baby at presentation had a high grade fever recorded as 1 or 2 degrees Fahrenheit. There was 1 episode of seizure at presentation and the baby was highly irritable. Coming to the maternal history, at 26 weeks of gestation, mother had vesicular lesion thought to be chickenpox. Treatment details were not available. At 32 weeks of gestation, mother had pyodermic lesions. The mother was treated with antibiotics, augmentin and T-back ointment. The case, the baby was started on oxygen, antibiotic, anti-epileptic drugs, Gardneril and supportive care. On clinical examination, the baby was highly irritable. There was excessive inconsolable cry. There were no such GI symptoms. There was no skin rash. There was no cyanosis. There was no mottled skin. On examination, heart rate was 180 per minute. Respiratory rate was 48 per minute. Saturation was 98 room air. Temperature recorded was 1 or 2 degrees Fahrenheit. Respiratory system, there was a bilateral entry. There was conducted sounds present. There was minimal RD. On CNS examination, the baby was irritable. Bilateral pupils were reacting to light. There were no bulging anterior fontanelle. So we went on to the workup. At the present, at admission, CRP was 11.
Yeah, before reports. Okay.
Sir.
So from your presentations, okay. So what inference you might be getting? Suppose before the examination suggests by the presenting symptoms. Okay. Go back. Then before going to back side. Previous one, first one. Okay. From this onwards, what you will be thinking process is going on? Thought process. Anatomically, pathologically, what you will be thinking of?
We are thinking about like viral prodrome.
Anatomy of the disease. Which system might have been involved?
The respiratory system.
So
And
you are
CNS.
thinking cough is their respiratory system.
Respiratory
Okay.
system.
Next, what could be the pathology? Fever, what it tells you?
Sorry, sir.
Fever is there. What pathology it tells us? Is it tells us ischemia, infection, inflammation?
Inflammation.
So inflammation in the airway you told.
Airways.
Next symptom.
Excessive cry and irritability, CNS involvement.
Okay, CNS. Is it directly CNS or secondary to respiratory? What you might be thinking of?
Maybe secondary to respiratory.
Okay, so airway obstruction, hypoxia resulting into you think of. Next, third thing.
Seizure episode.
1 episode of the seizure.
One episode.
Will you write seizure in presenting complaint or something else you are supposed to note it down? Seizure is a medical terminology.
Yes, sir.
Will you write seizure or could have been something?
Abnormal movements.
You could have meant abnormal movement. Okay.
Yes, sir.
So abnormal movement secondary to the respiratory. Why not? It is primary in the organism might have affected the both. Why not? It is.
Yes, sir. It could be.
Yes.
organism involving affecting both the systems, it could be the possibility also.
Yeah, that could be the possibility. Okay. Next. So from the next you come. So you are thinking of respiratory as well as CNS. Now,
CNS.
what is the pattern of the involuntary movement? Tells you.
Involuntary movement. There was posturing, sir.
Yeah.
Posturing and uploading of eyeballs.
Okay. Which anatomy in the brain it tells us posturing means? Will you expect the posturing in the newborn normally, routinely, any form? What is the commonest type of seizure we get in newborn?
Subtle seizures.
Subtles are common. But if this posturing is there, what might have been resulted into?
Could be a limbic system.
Anything? Yes. Is it only cerebral brainstem involvement can be possible?
Yes, sir.
Yeah. Okay. So it is the cerebrum, gray matters as well whole part. Now both half of the involvement is not a localizing. Okay. So you did not get the localizing. So diffuse involvement it tells us. Okay. Next. Continue.
Clinical exam.
Okay. So from that, what information you are getting? Excessive uncontrollable cry. What it means to you? What it means to you?
It could be a seizure also, sir. Baby is irritable, CNS involvement, maybe respiratory system hypoxia.
Will it tell us the either hypoxia or raised intracranial pressure?
Yes, raised intracranial pressure.
That is also possibility. So if you have thought of, have you observed for the bulging? No bulging of the fontanelle artery.
Yeah, no bulging.
Yeah. Okay. So there is no clinical evidence of hypoxia. Cyanosis was also not there. Mottling was also not there. Okay, next, continue. Continue. Yeah.
Yeah. Can I just interrupt 1 minute, if you don't mind?
Yeah.
Okay.
Please go ahead, Dr. Pritesh.
Yeah, investigations of CRP was 11 at admission due to fever spikes. As the fever spikes were continuing on to second and third day, when we repeated the investigation, CRP was increased to 45 on third day. Further investigations, dengue serology was negative. RT-PCR for COVID-19 was also negative. COVID IgG was 4.21. CBP, calcium, magnesium, electrolytes were within normal limits. CSF biochemical analysis and culture was also normal. NSG was done. EG was normal. CT brain was also normal. So as these primary investigations were normal, thinking something rare, we went into CSF. We had done CSF viral panel of the baby, suspecting viral etiology in the CSF. So that reports came out to be positive for HHV6. These are the reports. All other viruses were negative.
Now, if you are thinking of this point of time, this HSPH cause, when was the infection happened to the baby?
Viral infection. So there was a history of lesions, pyodermal lesions in the mother. So even we did RT-PCR of the baby.
No, that has developed in the 26 weeks of gestation, what I think so.
Yeah, 26 weeks.
Okay.
There was pyodermal rash, sir.
Okay.
So we have done the same RT-PCR of DNA of the DNA PCR of the mother also. It was negative, sir.
No, I just want to quickly 1 minute.
Do you think that the mother's lesions, whether it was herpes or not, whatever, at 26 or 32 weeks of gestation is responsible for the HSV encephalitis of a baby at 28 days?
No, sir. No, sir.
So that has got no relevance to this.
Yeah, no relevance.
Second, the baby weight was 4.2 kg. Okay.
Yes, sir.
Yeah. So it is unlikely to be. There is no growth retardation, intrauterine growth retardation in this baby.
No growth retardation, sir.
Yeah. So now you are attributing the same infection, or it is a different one?
Different one, sir.
Okay.
To rule out the vertical transmission, we have done that, sir.
Okay.
Although we knew it was something like a baby self infection. So to determine whether the baby was immunocompetent or immunocompromised, we have also sent a primary immunodeficiency panel of the baby, which came out to be normal. So going into treatment, baby was started on IV fluids, antibiotics, anti-epileptic drug. Gardner was loaded and maintenance doses were started, nebulizations and supportive care. In view of CSF viral panel positive for HHV6, injection ganciclovir was started at dose of 6 mg per kg per dose twice daily for 14 days. Oral ganciclovir was continued at dose of 30 mg per kg per dose thrice daily for 4 more weeks. We have read the following journals and we have come to the treatment of this baby, sir. The outcome, there were no fresh seizure episodes, irritability of the baby decreased, fever spikes were decreased, baby started accepting feeds well, and was discharged in stable condition on 7th day, sir. So coming back, why this case for presentation? It's a very rare case in infants. Only 20% of the infected cases develop as 80%. Am I audible?
Yeah.
80% go as unrecognized febrile illness. Very rarely infected cases manifest with the CNS involvement like seizures, irritability, encephalitis, and encephalopathy. There is lack of literature regarding how long to treat, duration of therapy, and whom to treat. Whether we have to treat immunocompetent, immunocompromised, CNS involvement, immunocompetent should be treated. There is a lack of literature regarding this.
May I request the participants to mute themselves, except the speaker and
Dr. Swapna. I request Dr. Swapna to unmute. Mute. Dr. Swapna.
Please proceed.
Yeah.
Yes, doctor.
It's a very rare case in infants. Only 20% develop RAS, 80% go as unrecognized febrile illness. Very rarely they manifest with CNS involvement like seizures, irritability, encephalitis, and encephalopathy. There is lack of literature regarding the duration of therapy, how long to treat, and whom to treat. Whether immunocompetent cases should be treated, and only immunocompromised cases should be treated. Whether cases with CNS involvement only should be treated. There is lack of literature regarding this. So we have found one similar case in literature in the Journal of Pediatrics and Neonatology, where 32 days baby, how was the case managed with HHV infection. What was the presentation? There was one episode of high-grade fever. There was cough since 1 day. In that case, from the literature, there was good activity. There was adequate PO intake. There were no GI symptoms, no irritability, no abnormal movements, no skin rash, no cyanosis, no mottled skin. But there was bulging anterior fontanelle. How were they treated? The sepsis workup was negative, chest X-ray was normal, CE was normal, NSG was normal. PCR for HHV6 in CSF came out to be positive. So the case from the literature, they were started on IV ganciclovir for 14 days. The outcome, fever subsided within 48 hours, baby was hemodynamically stable, and baby was discharged on 7th day. Summary. There is no data or clear recommendations for the treatment of neonates with HHV6 meningitis. Should neonate be considered like immunocompromised host and be treated with ganciclovir, or should they receive only supportive treatment? There is still a dilemma regarding this. So more studies are required to have an evidence-based antiviral treatment in this age group. Treatment of HHV6 meningitis with ganciclovir at the dose of higher dose, like 18 mg per kg per day, or foscarnet at 60 mg per kg per day in 2 divided doses, is recommended for immunocompromised patients, including immunodeficient patients, and those receiving chemotherapy or prolonged course of steroid. And this is the publication regarding the high dose of ganciclovir. Sir, need your input regarding this case. Have you seen this case in your practice? Any inputs regarding treatment guidelines, what we have followed?
Yeah, unmute, Dr. Soren, please unmute yourself.
Sorry, sir.
This newborn was born normal at birth, usually 4.2 kg at 28 days is telling means absolutely the other one has no IGR. So we might not be thinking of this is intrauterine infection.
Yeah. Yes, sir.
And the duration of illness is just 4 days. More than one systems are involved, respiratory and
CNS.
So, and the fever was there. So, we think acute viral fever involving the airway, actually the brain parenchyma. That's the basic thing we thought of.
Yes, sir.
So, based on the thing, as the anyway, whenever any baby is sick, we just want to rule out the bacterial infection first.
Yes, sir.
So, all the markers suggesting a bacterial infection has been ruled out. Then diagnosis has been made into acute viral encephalitis.
Yes, sir. Yes, sir.
So routinely that's going to be the diagnosis. HHV6 is very less common. We don't see, but fortunately you have the viral panel and you have made it the diagnosis.
Yes, sir.
Okay. That's all from my side. Dr. Pritesh, anything to add upon?
So yes, just a couple of things. So it's a good thing that the picked up. So a lot of these viral panels do help at times, like in this situation. 2 or 3 points from my side. One is the foscarnet is not recommended below 18 years of age. So though it is there as a immunocompromise and all,
It's only in
below
immunocompromised.
18 FDA approval. FDA approval is not there for below 18.
Okay.
It's only for above 18. Look
Okay.
into foscarnet. The second thing is, if we take the the literature from CMV, cytomegalovirus meningitis or meningoencephalitis, because CMV is also belongs to the same group, so that is probably seen more commonly. So the recommendations in CMV say that you document a negative PCR before you discontinue therapy. Actually, that is from the CMV I'm talking of a point of view. So maybe probably a similar thing should be taken here or not. I'm not very sure.
Infections.
Sir, we presented this case because we couldn't find any more literature in, especially in the neonatal age group, sir. Whatever we found, it was either in the adults who were immunocompromised in form of like cancer undergoing chemotherapy, or those suffering from secondary immunodeficiency like AIDS. Literature which are available, morely they were in pediatric age group, and they were treated with ganciclovir, but the neonatal like publications are not there, sir. So we wanted to know whether we have to treat, and as the baby improved like drastically after treatment, so how to go ahead, like whether to give ganciclovir as it is CSF positive, and how long to treat was our query, sir. Like, so we wanted to put this case for open discussion.
I think, Pragna, I think it's a wise idea to treat. I think absolutely right thing has been done by treating, because to some extent neonates or maybe even the infants in first few months would be to some extent immunocompromised. So, and then you have found it positive in CNS, child was symptomatic. So probably it's a right decision to treat. How long? Yeah, 14 days is usually recommended. That's why I said in CMV, they say you document a negative PCR before you stop.
Yes, sir.
So whether you can take that same thing here or not, that's debatable. But I would treat if I was in that situation, definitely.
Sir, and should we continue oral ganciclovir post like IV therapy? Like
No.
most of the publication did that, like they continued for another 14 days, like total of 1 month to 6 weeks of duration. So followed by oral therapy also.
Yeah, so that is again similar to what they do in CMV. CMV, once you document negative in CSF, then you continue oral therapy till you're able to document a negative urine or something, even in acquired CMV actually.
Okay.
So maybe it's right, I think. But I think you should treat.
And sir, when to repeat the DNA PCR, sir? Like after IV, completion of the IV course, or any specific?
It is recommended after 2 weeks.
Okay.
In this, I don't know. In CMV, it is recommended at the end of 2 weeks.
Yes, sir.
Yeah.
Okay.
Yeah.
Thank you, sir.
One more question. What is the follow-up you are going to do for this case? How long you are going to follow up this case? Any future
They're in regular
complication?
follow-up, sir. Now the baby is on oral ganciclovir.
Okay.
It was started. IV course was completed on 31st of this October, sir. From first we are started on oral ganciclovir. So the baby is doing well, sir.
Okay. Great. Thank you, doctor.
Thank you, sir.
Next case, second case will be from Paramita
Dr. Krishna.
Hospital. Dr.
Dr. Krishna,
Aparna.
thank you. Dr. Krishna, thank you. You brought in an interesting case, with an open-ended case.
Can we ask any questions?
Yeah, please, Dr. Anand.
Because I'm muted, I want to ask some questions to the Dr. Aswad.
Yeah, please go ahead, sir. Please. Yes, yes, you are audible, sir. Go ahead. Please go ahead.
Yeah. See, first thing, when you have seen the case, 28 days of the baby presented with respiratory symptoms, and what clues were given to think of the viral or something on examination? When this is
Your voice is breaking, sir.
abnormal movements and height of the anatomical or the jumped immediately doing the LP and got the viral serology, what investigations? Suddenly, how come you arrived the diagnosis like that?
Hello, Dr. Aswad. Dr. Aswad?
Hello, sir.
Yes.
Yeah, Dr. Aswad, could you understand the question?
Yeah, I couldn't hear, sir. There was voice breakage.
Dr. Anand, sir, please repeat your question. Please repeat your question. Dr. Anand, sir.
This 28, this newborn, 28 days of life, presented with the cough and cold, and fever is there, and abnormal movements. And when this presentation is initially with respiratory.
Your voice is breaking, sir.
Your voice is breaking, sir. There is no clarity.
You can type in, sir. Dr. Anand, sir, you can type in your
Chat box, sir.
You can type in your suggestion. Dr. K. Shall you move to the second case?
Yes. Sure. But thank you, Dr. Aswad. What a wonderful presentation.
Thank you.
Thank you. Next case from Paramita Hospital. It is about acute abdomen by Dr. Aparna and under Dr. N.B. Rao. Dr. Aparna, kindly share your screen. Thank you. Welcome, doctor.
You want to ask questions?
Good afternoon, sir.
Yeah, good afternoon. Please go ahead.
Present a case with three-year-old male child presenting complaints is pain, abdomen, vomiting, and abdominal distension since 3 days. History of presenting illness. Child was apparently all right 3 days back. Then he developed pain abdomen.
Dr. Aparna, 1 minute. Go back. First, go. So, what is your thought process going on based on this?
Any abstraction?
Yeah, no, anatomically.
GIT system
Okay.
maybe.
GIC system. Okay. So, if GIT is there, then pathologically, what might be happening? Pain is there. What is the pathology?
Inflammation.
So inflammation may be there. Okay. Next thing, distension of abdomen. How can you attribute most likely? Inflammation and distension. If I add together, what might be process is going on?
Intestinal pathology, maybe obstruction, sir.
Maybe obstruction. Okay. Okay, go ahead.
The child was apparently well 3 days back. Then he developed pain abdomen, which is insidious in onset, progressive in nature, generalized all over the abdomen. It is severe and unremitting. There are no relieving factors, and it is not associated with food intake. Vomitings 3 to 4 episodes per day, which is bilious in nature, non-projectile, non-blood stain, and it is not aggravated by food intake.
What bilious implies to you here? Bilious vomiting.
Post-waiter.
Post?
Waiter.
Okay. Second, after the second part of the duodenum. Okay. Next.
Abdominal distension since 3 days, which is insidious in onset, progressive in nature, and uniformly distended. The child has not passed stools or flatters since 2 days.
Now, when the duration is less than 1 week or so, you cannot tell insidious. Insidious onset means when you cannot pinpoint at which point of the time disease process has started. Okay, these are the acute onset actually. 3, 4 days, 7 days, because they are knowing, okay, this particular day it has started. Basically, the malignancy, autoimmune disease, they will be long standing, 2 weeks, 3 weeks, or 1 month. There you will use more of insidious onset. Okay. So these are acute onset.
Okay.
Now, what might be think process after this, knowing the history of present illness?
I thought of interception or obstruction in the child because
okay. So now first thing you will think obstruction resulting into distension and the vomiting. Okay, and the obstruction is below the second part of the duodenum.
Second part of the duodenum.
Okay. So now, if it is obstruction, what type of pain you should have expected?
If it is like small intestine, the child gets relieved after vomiting.
Okay. So,
intermittent in small intestine.
Yeah. If it is intermittent pain you could get, then you could be.
But this child is having continuous pain.
Continue, Dr. Aparna.
Okay. There is no history of fever or any foreign body ingestion or cough, excessive cry while passing urine. There is no history of travel or outside food intake. There is no history of jaundice or lump in the abdomen. The past history is not significant, sir. Antenatal, natal, and postnatal history are normal.
Okay.
Immunization, the child vaccinated as per national immunization schedule. The diet history is the adequate protein and calorie intake was present, sir. He is developmentally normal, appropriate to his age. Family history, he is firstborn male child out of non-consanguineous marriage. They belong to lower middle class according to Kupuswamy classification. They live in a 4-roomed home with 2 rooms, an attached washroom. They used filtered drinking water. Summary, a 3-year-old boy, premorbidly normal, developmentally appropriate to his age and immunized for the age, presented with the complaints of pain, abdomen, vomiting, and abdominal distension since 3 days. So my DDs are straightforward to acute intestinal obstruction or intersusceptions. As it is bilious vomitings.
Okay.
Shall I go further, sir?
Yeah, you can continue.
On general physical examination, the child is active and alert. There is no pallor, no icterus or no lymphadenopathy. Vitals are stable. Head to toe examination is normal. Anthropometry is also normal, sir. Appropriate for his age group. GIT systemic examination. So upper GIT examination leads oral cavity and tongue is normal, sir. Per abdominal examination on inspection, abdomen is uniformly distended, skin over the abdomen is normal, and umbilicus is inverted. All coordinates are moving equally with respiration, and genitalia is normal, sir. On palpation, there is diffuse tenderness all over the abdomen. There is no organomegaly, and there is no abdominal mass. On percussion, there is resonant note, and on auscultation, bowel sounds are present, sir. The rest of other systems are normal, sir, like CVS, respiratory, and CNS. So further, we have investigated the child with X-ray erect abdomen, ultrasound abdomen, and serum electrolytes with basic investigations, baseline investigations. So on X-ray, there were.
Aparna, before going to the investigations, okay, by looking at the child when he is by observation of the child, can you diagnose few acute condition, acute abdominal pain, just by observation?
Yes, sir. By the position of the child while sleeping.
Yeah. What are they things?
Yes.
Yes. Can you examples?
If there is peritonitis or like the child sleeps in the curved position, bending to.
Peritonitis, child will bend or child will remain stand still, he will not move at all.
Stand straight.
Yes, child will not be moving at all. Now, if the breathing movement is there, child is scrolling around.
Yes, sir.
Yeah?
Yeah, sir. Knee chest position will be there.
Knee chest position. What knee chest position? Yes.
In severe pain, for the comfort of the child.
Anything else? Now, how the child will look if child having a pancreatitis? Which position child will assume?
In knee chest position, sir, in pancreatitis.
No, not knee chest position. Knee chest position you will not see. Okay. Yeah. Which position baby will be more comfortable?
Up, bending over positions.
No. Front position. Backside usually radiates to the pen to the back. Okay. So anything else by looking at the child, you can identify the severe excruciating pain, other thing. Other than this condition. No. So now with the pain and could have been added pallor is there. Sudden onset of pain is there and there is a pallor.
Bleeding inside.
Bleeding, no. Anything else? Any conditions comes with the pain abdomen? Anemic condition, hematological condition coming with pain abdomen. Acute pain abdomen, hematology. Yeah?
Thalassemia may be present.
Thalassemia, no. Sickle cell anemia.
Sickle
Okay,
cell.
vaso-occlusive they will be coming. Porphyria, they will be coming to you. Okay. Now, if the pain could be there, acute pain abdomen is there, and there is a palpable purpura.
HSP.
They will be coming with the pain abdomen. Okay. Yeah. Okay. So these are the common things.
Yes, sir.
Okay. Acute. Now the thing is, what can you tell this baby if only pain abdomen is there, history of vomiting is there, pain abdomen and vomiting.
Gastritis.
And they are getting in rapid breathing.
Diabetic acidosis.
Diabetic acid with retractions. Acute severe pain abdomen, tachypnea, retractions. Lower lobe pneumonia. You will get referred pain also. Okay, abdominal pain. Those are the things. Okay, next, continue.
On investigating the child and X-ray, there are multiple air fluid levels present, sir.
Okay.
And the ultrasound, they have given the colon thickness at splenic flexure with 7 to 8 mm in the thickness. So we thought it is acute intestinal obstruction and we took the case for emergency laparotomy. But Intraoperative findings were like left mesocolic hernia, sir.
Okay.
Unfortunately, Bhuvneshwar sir is not available. Sir told he will speak on this.
We had presented this case because of its rarity. We searched the literature, we could see hardly 5 or 6 pediatric cases having mesocolic hernia.
Okay.
But they should be kept in our mind, otherwise they can lead to catastrophic changes. For that reason, we had presented it. We didn't have time to take CT abdomen. The pain was excruciating and child was very irritable. Child was taken to theater within 4 hours. Lab was done and the findings were mesocolic hernia at spleen flexure.
Aparna, are you audible? Aparna.
Yes, sir.
Yes, sir.
So this what you have presented, very nice case. Anyway, I will ask only one question regarding
Your voice is breaking, sir.
Acute
Dr. Ananda, sir.
Thinking anatomical obstruction.
Sir, Dr. Anand, sir.
They clinically how affected.
I'm calling.
Sir, Dr. Anand, sir.
Pain abdomen and distension is there.
Sir, Dr. Anand, sir, your voice is not clear, sir. Can you write it down, sir, in the chat box? Your query. Your voice is breaking,
not
sir.
Clear. Okay.
Yes, sir. It's very breaking, sir. Your voice
Breaking voice. Yeah, the internet may be problem.
Yes,
Yes,
sir.
I wanted to ask the Aparna, clinically how to suspect where is the site of obstruction for this the bilious vomiting, pain abdomen and distension of abdomen.
Dr. Aparna.
Based on vomitings, history of vomitings,
Yeah.
it gets relieved in small intestine obstruction. The pain gets relieved after the child had episodes of vomiting, sir. And the pain is early in presentation in small intestine obstruction, where it is in large bowel obstruction, it is late in presentation.
Great. So vomiting is there in your case. Where obstruction. Okay.
Yeah, your voice is breaking, sir. She couldn't get your question actually.
Anand sir, you can. Anand sir, you can switch off the video. You can audio mode. You can ask, so it will be better.
Okay. Okay.
All right. Dr. Aparna. Yeah, Dr. Anand wanted to know exact which site is a block, which site is a obstruction, like which place, like between duodenum, after duodenum or small intestine, which place?
Large intestine, sir. Colon.
Okay, doctor. Anything you want to?
It was near the transverse colon ending and the descending colon starting. We never thought it's mesocolic hernia. It's only after opening the abdomen we could find that mesocolic hernia.
Okay. Go ahead, sir. Go ahead.
Go ahead.
No problem.
Okay. Any queries? You can go ahead, Dr. Aparna.
So, mesocolic hernias
Any-
are rare congenital lesions due to abnormal rotation of gut. There is a potential anatomical space between mesocolon. Between mesocolon and retroperitoneum, there is a space where there is a leading point for hernial sacs. So when most case reports are seen in the adult, though it is congenital lesion, most of the case reports were seen in the adult age groups. So it is rare to get in a pediatric age group with that too with an acute obstruction. So this is the image for right mesocolic hernia and left mesocolic hernia. So into this sac, the intestinal loops goes in where it causes the hernia, sir.
So this child had the pain abdomen, then vomiting, then distension of the abdomen.
Yes.
The characteristics of the pain, as it is episodic, tells it may be a hollow viscous obstruction. That's the characteristic of it. Continuous dull ache basically tells us the inflammation. So it is not the primarily due to inflammatory process. Or next thing is the vomiting. Bilious vomiting tells us this obstruction wherever may be there is it's below the second part of the duodenum. Third thing is diffuse distension tells more towards the small bowel obstruction. Okay. So these are the three things we have got it. So any cases of acute abdominal pain. So we first and foremost think to whether it is GI pathology or it is a systemic disease. Okay. Other systems involvement, just like we have told you, it may be metabolic acidosis, it may be lower lobe pneumonia. Occasionally, we have seen child presenting with just pain abdomen, subsequently developing other thing. If they have a recurrent episodes are there previously also, or with an anemia, we'll be thinking of cases with sickle cell anemia. Other than the GI are depending upon the progression, the fever, vomiting and pain abdomen, which is the dominant symptom will tell us. If the dominant symptoms are the pain abdomen, appendicitis is the commonest one. If dominant symptom is the fever, then maybe pyelonephritis or enteric fever. Okay, if the dominant is the vomiting, so it tells it acute viral hepatitis. Okay, so these are the three things we can do from the acute abdominal pain. Okay, so yours based on the pattern of the vomiting, as the pattern of the pain, it tells in a obstruction. That's all. Dr. Pritesh, any comment from your side?
Dr. Pritesh? Sir, are you there? Dr. Pritesh?
Okay.
Okay, we'll
then we can go for the next case, sir.
Next case. Next case, little change is this in the sequence is from Apollo Hospital. Thank you, Dr. Aparna, for a wonderful presentation. Thank you. Next is from Apollo Hospital, Dr. Sneha. Are you there? About pyrexia of unknown origin.
Hello, am I audible, sir?
Yes, yes, you're audible. Your screen is visible. Make it full screen, no?
Good afternoon, one and all.
Please make it full screen, no, Dr. Sneha?
Yes, sir, I made it full screen.
It's not coming.
Ma'am, please close and do once again, ma'am. Please close it and do once again.
Change about let's say.
Okay.
The full screen brightness icon change about.
Okay.
So is it visible, sir, now?
Yeah, it's visible, but it's not full screen. Doctor. Yes. No, you can carry.
Is the slide changing?
No. The first slide you can see. You can see the first slide.
It is changed here. But not
here we only not here. We are not able to see. Only first slide we are seeing.
Yeah.
Back in. Slide share. Screen share.
Is it visible now, sir?
It's visible, but change the. Yes, no, it's changing. It's changing. Slide is changing, but it's not full screen.
Okay, sir.
Okay, we will go ahead.
I'll continue like this, sir.
Yes, no problem. Carry on, please. Go ahead.
There's a 6 month, 12 days old female baby who is a resident of Budwell, presented to us with a history of fever since 22 days. The child is having fever since 22 days, which was low grade and intermittent. The intensity of fever was the same throughout the period. And on day 3 of fever, the child was admitted in local hospital, where the child received antibiotics for 3 days. And in view of persistent of fever spikes, the child was referred to another higher center. Even there, the child continued to have low-grade fever spikes. And on day 6 of fever, they noticed some maculopapular rash, which was present on cheeks, upper limbs, and lower limbs. And there is no specific progression of rash. There is no specific progression pattern of rash. And it subsided within 5 days. And in that hospital, the child was almost admitted for 16 days. And the child was evaluated and received multiple antibiotics. But the fever didn't subside. There, the investigations revealed.
1 minute. Dr. Sneha,
yes,
as
sir.
you are telling on day 6, rashes is included and fever is of 22 days. So it should have been included in the presenting complaint, rash.
When the child presented to us, there is no rash, sir. But only the history, when we asked about that, they have given the history of rash, and it was only present only for 2-3 days. And later it subsided.
But once you are telling age fever for 20 days, 22 days, within that time frame itself, this was their rash. Okay?
Yes, sir.
Day 6, so should have been included in the presenting complaint, because which day patient has visited you?
Okay, sir. Okay.
Which day of the illness patient has visited you?
On 22nd day only, sir.
So by the time rash is already occurred, na?
Yes, sir.
Yeah, so that should have been included.
Yes, sir.
So now, based on the thing, you are thinking of day 6 of the fever.
Yes,
sir. Can you tell based on the day fever with rash, which day rash will appear? First day rash, second day, third day?
There was no rash before coming here. Only after admission the rash has come.
Okay, after day 6 of hospitalization, patient has developed rash.
Yes.
Okay. Okay, still for her knowledge sake, can Sneha tell
Yes,
Fever
sir.
with rash.
Like a fever with rash on
The
day.
first day of the fever rash.
On day one, if there is a mnemonic also, sir, for this, child can take 2 tablets so that we can remember. On day one of fever, if there is rash, varicella, it is, sir. Day 2,
Okay. Yeah.
Day 3 is smallpox. Day 4, there is rash, it is measles. Day 5, some typhus. Day 6 is dengue. Day 7
Okay.
is typhoid.
Okay. So this baby came with the 22nd day, but after
Yes,
the
sir.
6th day means day 28, the baby developed a rash.
Yes, sir.
Yeah. Okay. Next, continue.
The investigations what we have done on outside hospital.
Now, so before investigation, what is the think process is going on?
Here the child is having fever and intermittent, and the child is also having a history of rash.
Okay.
So basically, most commonly we are thinking in terms of infectious conditions, sir.
So you will be thinking of infective or some non-infective also will be causing a rash.
Yes, sir. Yes, sir.
So now the pattern of fever, what it tells you, infective or non-infective?
It can
Is
be.
it any specific pattern this 20 or 22 days?
No, sir, there is no specific pattern. The child was having low-grade rash almost daily. And the child was having 1 to 2 fever spikes per day.
Okay, 1 to 2 fever spikes per day. If you are
Yes, sir.
expecting 2 fever spikes per day, which condition you will get? Every 12 hours, if the child have fever, which condition you will think of? Yes. Any systemic illness? Yeah. Usually systemic onset juvenile idiopathic arthritis. They will be presenting twice a day. Pick.
Okay, sir.
All autoimmune disease. Yeah.
Okay,
Next.
sir.
Continue.
Yes, sir. From further history, there is no history of seizures or loss of consciousness, no history of any ear discharge, rubbing of ears, no history of coughing or fast breathing, no history of vomiting or loose stool, no history of yellowish discoloration of eyes or skin, no history of any bleeding manifestations, no history of passing urine or increased frequency of micturition, no history of increased intake of feeds and contact with tuberculosis, and no history of any recurrent boils. And the child was brought here for further management. Past history, the baby had history of fever once every month, which lasted for 1 to 2 days from 3 months of age, and it was relieved on taking paracetamol, and no history of any previous hospital admissions.
Okay, so what it means to you? 1 minute. Go back.
Yes, sir.
Okay, the previous slide.
Yes, sir.
Yeah. So once every month, baby had a fever once in every month, lasted 1 to 2 days from 3 months of age. What it implies to you? Now it is 6 months of age. Okay.
Yes, sir.
So from 3 months it had started.
Yes, sir.
Okay. So almost 3 months history is there. So what can you tell common causes of fever since 3 months or more?
It indicates there is some chronic process going on, sir. Some inflammation.
Okay. Now what could be the etiological things? Long duration of fever in children.
Autoimmune.
Okay. Autoimmune like? Yes, any process? Any infection also can process? 3 months? This age group?
Any abscess?
abscess will not belong anything else. Will it be child immunodeficiency, HIV? Can we have?
Yes, sir.
Can we have some genetic causes which may be causing a long-standing thing? Okay, dysautonomia and all. Okay, can we have long duration with the hydrogenic drug-induced fever?
Yes, sir.
Yeah. Can we have a hypothalamic problem, dysfunction? So these are unusual causes you have to think of if the 3 months or so. So you will not think of commonly infective are less likely over long duration. If infection is only tuberculosis and HIV.
Yes, sir.
Yeah. Okay. Next, continue.
Antenatal history. She is a primary of marital life 19 years, conceived by IVF, and it's a registered pregnancy with regular antenatal visits, took iron and folic acid supplements, and there is no history of fever with rash or lymphadenopathy.
Okay. So what it rules out these two things?
Rules
Okay.
out infections can be ruled out.
Fever with rash in the mother. Okay. So what you are ruling out?
Torch infections.
Yes. Fever with rash and lymphadenopathy in mother. So which infection you want to rule out?
Toxo.
Rubella, basically. Fever rash.
Yes.
Okay. Next.
Natal history. The baby was delivered by elective cesarean section with birth weight 2.7 kgs. And the baby cried immediately after birth, and breastfeeding was initiated within 1 hour of birth. And there is no history of any NICU admission.
Okay, so now the thing is the baby was normally weight at birth.
Yes,
okay.
sir.
Is there any documentation of head circumference also?
No,
Length
sir.
also? No documentation. So almost 2.7 kg, it tells unlikely to be a intrauterine infection.
Yes, sir.
Yeah, okay. Next.
Age appropriate milestones were achieved.
Okay.
Nutritional history. Breastfeeding was started within 1 hour after delivery, and the baby was exclusively breastfed till 6 months of age. And complementary feeding was also started after 6 months of age.
Okay.
The baby was immunized according to national immunization schedule and last vaccinated at 5 months of age.
Okay.
The baby was born to a non-consanguineous parents of first order. There is no history of any fever in the family.
Okay.
Socioeconomic history. They live in Paka house with adequate ventilation, no pets at home, and they belong to upper middle class family. So summary, 6-month, 12-day-old female child with history of fever since 22 days, associated with rash for 6 days, with no significant family history, already admitted in another private hospital for almost 18 days, where they had elevated WBC and elevated CRP, and the child received multiple antibiotics for the same. But there is no relief, due to persistence of fever, even after 18 days of hospital admission, the child was again referred to us.
Okay.
On examination, the child was conscious and alert, sir. Temperature was 102 with respiratory rate of 32 and pulse rate of 132. Capillary refill time was less than 3 seconds, and saturations also at room air were 98%.
Okay.
Anthropometry, length was 64 centimeters, which is falling between 3rd to 25th centile. Weight, present weight is 5.785 kgs, which is coming less than 3rd centile. Head circumference is 41 centimeters, which is falling between 3rd to 25th centile. And chest circumference is 43 centimeters.
But when you come to 5.7 kg, 6 kg baby, so okay, 5.78 kg, but birth weight is 2.7 kg. Okay.
Yes, sir.
So usually 5 to 6 months you will be expecting a double.
Yes,
okay?
sir.
Almost doubled.
Almost doubled.
Birth weight
Yes,
has been doubled. Yeah. So but it is falling under less than third centile.
Yes, sir.
Okay. So is it the disease process per se causing this growth failure? Yes. So how you could have known? You could have plotted that centile at birth also. So then you could compare birth weight, what centile is there now present. If there is a major centile fall is happening, suppose birth weight at birth it is 15th centile, now it is falling below the third centile, then it is abnormal. Otherwise, if you have absolute status, you will consider around 5.7 or 8 kg, it is normal.
Yes, sir.
Okay, so you could have plotted that one. To tell the fall in the major centile, to tell it is abnormal.
Okay, sir.
Okay.
Head
So
to
next.
Head-to-toe examination, there are no dysmorphic phases, sir. The positive finding what we had was the cervical lymph nodes were palpable of 1 to 1.5 centimeters, and there were multiple. BCG scar was present, and even inguinal lymph nodes also were palpable, sir, of 1.5 centimeters, and multiple inguinal nodes were palpable.
Okay, so what information? Okay, so from the general examination, okay, continue.
On systemic examination, there is hepatosplenomegaly.
General examination, you can inference. Can you give some inference from the general examination?
So, including with history, the child is having fever almost for 22 days with the rash, and there is generalized lymphadenopathy.
Dr. Sneha, we just asking you inference from the general examination. In your case, what inference you might be thinking that
just
process?
Summary. Any information from
general examination?
Sir, the clue what we got is there is lymphadenopathy, generalized lymphadenopathy, which is significant.
Yeah. So what it may be telling you? What process it tells you? Long-standing fevers for last 3 months fever and generalized lymphadenopathy.
One thing is TB we can think of, sir.
Okay. Is there any anemia? Is there?
Yes, sir. Pallor is also present, sir.
Now, if the pallor is there any evidence of ecchymosis or petechiae?
No, sir.
Not there. Okay. So now, is it a disease of bone marrow or reticuloendothelial system you are telling?
Yes, sir. We are thinking in terms of those reticuloendothelial system and involvement of bone marrow.
Okay. So that's the thing. So, but platelets are not involved, you are telling. Okay.
Yes,
so
sir.
if those things are there. So what would be the
anemia.
differential diagnosis this point of time? So fever, anemia, generalized lymphadenopathy. So what are the differentials at this point of time?
One is the infection, sir.
Infection like?
Tuberculosis, torch.
Okay. Your torch is out because birth weight is normal, you told.
Yes, sir.
Okay. It was otherwise healthy baby at birth.
Yes, sir.
So tuberculosis to the baby could have been very sick. Okay. Anything else?
Any inflammation?
Could it be HIV infection?
Yes, sir.
Okay. Could it be subleukemic or aleukemic leukemia presenting in infants?
Yes, sir.
Could it be other bone marrow inflammatory infiltrations? Okay, so at least these are the things what comes to our differential. It is a disease of reticular endothelial system, may be infective or non-infective. Okay, next.
Yes.
Continue.
On systemic examination, per abdomen, there is hepatosplenomegaly, sir.
Okay.
Liver was palpable around 6 centimeters below the right costal margin, which is smooth. Surface is smooth and soft in consistency. There is no evidence of any free fluid in the abdomen, sir. Respiratory system wise, the child, it was normal, sir.
Okay.
CVS and CNS also were normal, sir. There is no abnormality found in the on systemic examination, sir.
Okay.
From hepatosplenomegaly. So here the summary: 6 month, 12-day-old female child with history of fever almost for 22 days, rash, anemia, hepatosplenomegaly, and lymphadenopathy.
Can you repeat us the characteristics of the rash? It has started on day 22 or 28 of.
Rash started on day 6, sir.
Okay. Day 6
there
of
is no
illness.
specific progression. Day 6 of illness, sir. There is no specific pattern of progression, sir, of the rash.
Then what is the characteristics of rash? Type.
The maculopapular rash was present, sir.
Okay. So what condition you might get maculopapular rashes? Which remains for few days and then subsides. Common condition, can you list maculopapular rashes? Yes. Common examples where you will get maculopapular rashes.
Viral infections we can get, sir, like measles.
Okay. Measles and rubella and all you will get.
Measles
okay.
and rubella.
Okay. Do you think this process has something viral infection that has triggered and has further the disease progressed? Or this rash is a part of the disease per se? Is it a separate entity or a part of disease you want to include?
It could be some superimposed viral infection, which also has occurred, sir, in this child.
Okay. So now you have already all symptoms you have enlisted. Then what is your provisional diagnosis? Okay. This is just a summary, provisional diagnosis.
Yes, sir. We are thinking of infections and immunological conditions, primary immunodeficiencies, and lymphomas and leukemias, sir.
Okay. So now each things you tell the differential. Why not it is torch or why it is torch?
Yes, sir. One thing, it is not torch because the history what we got from the mother, there is no lymphadenopathy. Birth weight of the child was also normal. Head circumference is normal.
Okay. So there is no growth, intrauterine growth retardation, microcephaly, cataract, nothing was there. Okay.
Yes, sir.
So now why tuberculosis? If it is tuberculosis, which form of tuberculosis?
Congenital tuberculosis, one thing we have to rule out, sir, in this child.
Okay. Now in the congenital, again two things. The transmitted in utero, transmitted during the delivery. Okay.
Yes, sir.
How to differentiate the thing? If the transmission has occurred while during the process of delivery, what type of tuberculosis you will get?
Hepatic involvement will be there, sir.
So that is congenital form, hepatic involvement or systemic variety you will getting. But during the delivery, baby aspirates the thing, so you will get a pulmonary tuberculosis if it is there. Okay. Next, immunological Kawasaki. What is in favor? What is against?
In favor, we are having only fever for more than 5 days, sir.
Okay.
And lymphadenopathy.
Will we expect last 3 months fever in Kawasaki? That much duration?
No, sir.
Okay, from 3 months to 6 months?
No, sir.
Okay. So other than that, what type of rashes you expect in Kawasaki?
Peeling of skin will be there, sir, in Kawasaki.
Okay. Any other things you will get? Will you get lymphadenopathy?
Erythematous rash will be there, and non-purulent conjunctival suffusion will be there.
Okay.
Tongue, strawberry tongue.
Okay. But lymphadenopathy, what type? Which lymph nodes get involved in Kawasaki?
Mostly cervical lymph
Okay.
will be there.
Unilateral cervical.
Unilateral cervical lymph nodes will be there.
Why you are telling it is MIC? Will you expect this long duration it will remain? 3 months?
No, sir. But there's a COVID pandemic it was going on. We just wanted
It will not remain so long. Okay, 3 months or so.
Yes,
Next.
sir.
Okay, next continue. You can continue. Okay.
Yes,
Further.
sir. So we have investigated the child's. Our investigations, we found that on CBP, there is anemia of with the HB of 8.4 and TLC count is elevated, sir, of 24,560 with platelets around normal, 4.75 lakhs. And in that differentials, we found there is absolute eosinophil count was 2,210, sir. Peripheral smear relief.
Please continue.
Peripheral smear revealed erythropenia with microcytic hypochromic anemia, neutrophilic leukocytosis with few reactive lymphocytes, and an absolute eosinophilia. And it is negative for malaria and filaria. ESR, CRP was 55, so raised ESR and CRP. But Procal, it is a low risk for any serious infections. LFT was normal. And the other basic fever workup with what we did like malaria, dengue, and typhoid was negative. Blood culture was showed no growth. The second line workup we have sensor for any other infections like leptospira, scrub typhus, torch, which were also negative. And thinking of tuberculosis, we have sent gastric aspirate for CBNAT, which was negative. And to rule out rheumatoid arthritis, juvenile rheumatoid arthritis, ANA profile and RF factor was done, sir, which was negative. One thing we were suspecting was primary immunodeficiency, sir. So we have done immunodeficiency panel in that which was normal, but in that serum IgE levels were found to be elevated, sir, of 2,400 international units. This, viral markers screening for HIV and HBsAg were negative, and the other VAT electrolytes were normal. PTA-PTT was also normal. Ultrasound neck revealed cervical lymphadenopathy. Ultrasound abdomen showed mild hepatosplenomegaly. NSG was done, which was normal, sir. Chest X-ray was normal. And CT abdomen revealed hepatosplenomegaly with bilateral iliac and inguinal lymph nodes, largest measuring 1.2 to 1 centimeter. CUE was normal. This is the immunodeficiency panel, sir. And in view of prolonged fever workup, we have done MISI workup, which was negative. SARS antibodies were positive, and 2D echo was done to look for coronaries, which were normal, and even we wanted to rule out any infective endocarditis, and which showed no vegetations in 2D echo, sir. Which showed features consistent with hypereosinophilic syndrome. Flow cytometry was done with to rule out neoplasms like leukemias. We did flow cytometry, which was negative for the neoplastic clone. BCR ABS was done to rule out ALL and AML, CML, which was also negative, sir. And to rule out congenital like family history, allergic history in the family, even parents hemogram we have done. As in the hemogram, we got absolute eosinophil count of 2,200. We wanted to rule out any eosinophilia in the parents. So we did parents hemogram, which was also normal, sir.
Okay.
Karyotyping was performed by the bone marrow aspirate, sir, which also revealed normal phenotype, female karyotype. And no numerical structural chromosomal abnormalities were found, sir. Bone marrow biopsy also revealed hypereosinophilia. Bone marrow culture showed no growth. And bone marrow CBNAT also we have done, sir, which was negative. We have even we even did cervical lymph node biopsy, sir, and sent for analysis, which was suggestive of reactive lymphadenitis, and cervical lymph node CBNAT and AFB stain were also negative, sir.
Okay.
And we even did the whole exome sequencing, sir, as we were getting the only clue was eosinophilia with no other specific organ involvement or any end organ damage. So we wanted to see like what are the genetic diseases we wanted to rule out. So we did the whole exome sequencing, sir. So summary, 6-month, 12-day-old female child with the history of rash and hepatosplenomegaly, anemia and lymphadenopathy with peripheral smear and bone marrow biopsy aspirate and as per suggestive of hypereosinophilia and elevated IgE. And since no other cause of hypereosinophilia was found, sir, we made the diagnosis of idiopathic hypereosinophilic syndrome, and we started the child on prednisolone 1 mg per kg per day. And the child was even followed up with hemogram after including peripheral smear after 1 week. And there is improvement in HB, and even the total counts were decreased, sir. Though it was very soon to comment on the decrease, but there is an absolutely there is an improvement when compared to the reports in our when the child was admitted. And here even the eosinophil count also reduced to 1, so the percentage was 1. So basically, we treated this child as idiopathic hypereosinophilic syndrome, sir, and the response after starting with the steroids, there are even no fever spikes. The child also improved well, sir, and still the child is on follow-up with us, sir, now. So basically, idiopathic hypereosinophilic syndrome is characterized by sustained overproduction of eosinophils, where the count is more than 1500 cells per microliter for almost 6 months or longer, or at least on 2 occasions, it is more than 1500, or with evidence of tissue eosinophilia, absence of any other diagnosis to explain eosinophilia, signs and symptoms of organ involvement, and the organs most commonly involved are pulmonary, cutaneous, neurologic, serosal or GI involvement will be there, sir. Hypereosinophilic syndrome, it is in this peripheral blood smear eosinophilia will be there, and evidence of end organ damage or dysfunction will be there, sir, and these are directly attributable to tissue eosinophilia. Myeloproliferative hypereosinophilic syndromes in which there is clonal eosinophilic involvement will be present, sir. Lymphocytic hypereosinophilic syndrome, where there is aberrant lymphocyte population will be there. The overlap of hypereosinophilic syndrome, where the disease is restricted to a single organ system. Idiopathic, there is no cause meeting the criteria of any of these, then idiopathic hypereosinophilic syndrome diagnosis should be made. Hypereosinophilia of unknown significance with sufficient clinical workup finding or clinical or laboratory signs or symptoms, and there is suggestive of end organ damage or dysfunction that could lead to eosinophilia. Secondary hypereosinophilia, in this setting, there is an underlying disease which is associated with eosinophilia. Probably hypereosinophilia, it is associated with an underlying condition, but it is uncertain that the condition is leading to hypereosinophilia. And the treatment for idiopathic hypereosinophilic syndrome is mainly suppressing the eosinophilia by corticosteroids. And imatinib mesylate is effective in FIP1L1 platelet-derived growth factor alpha negative patients. And it is with this FIP1L1 PTGFR mutation, we can differentiate idiopathic hypereosinophilia from leukemic hypereosinophilia. And in patients where the corticosteroids, the patients whom they are unresponsive to corticosteroids, hydroxyurea or interferon alpha are used. And in patients with prominent organ involvement and who fail to respond to the therapy, there is a mortality of 75% after 3 years of age. Sir. Thank you.
Okay, so nice case, Dr. Sneha. So usually whenever we come across the prolonged duration of fever, actually, usually they are the uncommon presentation of the common diseases. So when we evaluate, we are supposed to rule out the common diseases first.
Yes,
as far as the pyrexia of unknown origin is concerned, according to the Nelson, there are 4 types. One is the classic pattern, what we'll say. Okay.
Yes,
second is the hospital acquired, hospital associated chronic morbid patient, hospitalized with long duration. Third is immune deficiency. Fourth one is HIV related. Because initially, once you have, it is not hospital acquired. if not HIV is negative, or it is not immunodeficiency, if those things are. And immunodeficiency, classically, you will have multiple fungal infection if it is a T cell variants, or once you are getting a prolonged BCG scars are there. Eczema, if you are getting. So these are marker or recurrent unusual infections. Okay, prolonged duration, abscess, otitis media. So then we'll be thinking of immunodeficiency. These are less common, but commonest one is the classic pattern. Okay, which will be diagnosing when the fever. First and foremost thing, when you will get that case, stop all the medications.
Yes, sir. That's what we did, sir. Here.
Stop, observe for 1 week.
Yes, sir.
Then record the temperature to confirm it is having a fever. So by the time we'll be starting in evaluation. But if there is a risk for generalized danger signs are there, then empirical treatment has to be started. Otherwise, we have to regularly re-evaluate frequently and detail history, and every day we'll have to examine the skin changes, skin, eyes, hepatosplenomegaly, lymphadenopathy, bony tenderness has to be examined. And commonest again in India, commonest is the infection, unusual long-standing infection, including sometimes the UTI, tuberculosis, okay, and deep-seated abscess, they may be presenting. Other than the infection is the autoimmune disease process and malignancy. Almost all the things you have evaluated, you have done a good job for evaluating this case. Okay, thank you.
Thank you.
So Dr. Pritesh.
Dr. Pritesh?
I think he's not available.
He is not available.
Okay.
Yes. Okay. Any queries from anybody? Yeah. Dr. Sneha, it's a very good presentation, very nice case you evaluated, very nice information you given, quite nice follow-up, and thank you very much to you and Dr. Sri Krishna also.
Basically, this already 20 days got treatment outside. After coming here, stopping the treatment and observing is a really tough job, because you have to convince the patients. Just we are keeping the patient for observation. So, but it finally it gave some diagnosis, and the patient has improved. After that, we did a follow-up for 3 months. Still, patient is all right.
How many days the patient was in your hospital?
Is there again to 3 weeks there?
3 weeks. Okay. Right.
Oh,
congratulations. Thank you. Next case. Thank you, Dr. Sneha. Next case will be from Nilofar Hospital by Dr. Likita and Dr. Srinivas Kalyani about a case of vomiting, icterus, and poor weight gain. Dr. Likita?
Good afternoon, everyone. This is a case from Nilofar Hospital under the guidance of Dr. Srinivas Kalyani, sir, Professor of Pediatrics, Nilofar Hospital. Here, a 2-year-old female child named Aradhya, resident of Tandur, was brought with the chief complaints of not gaining weight as compared to the peer group since birth, vomitings since 5 days, yellowish discoloration of eyes since 5 days. Parents observed that the child...
Dr. Likita, from go back. So from that, what is the inference? What you might be thinking of thought process?
So child is having failure to thrive.
Okay. So what it implies to you?
There are multiple etiologies for failure to thrive.
It implies it is a chronic progressive disease process. Okay.
Yes.
Next thing.
With the vomitings and yellowish discoloration.
Yellow color of eyes. What it tells you?
Now recently the child developed GIT symptoms also, sir.
Okay. Now if these two things are there, what could be things? Which system is involved?
Now GIT system is involved.
Now if you are thinking of gastrointestinal, is it the intestine or the liver or pancreas? All the things are there now. Which could be?
Here most probably liver is involved, sir.
Okay, liver is involved. If liver is involved, liver parts are including reticuloendothelial cell, hepatocyte, biliary tree, and portal venous system. What could be involved?
Yes, most probably hepatocellular disease.
Okay, so you might be dealing a chronic hepatocellular disease process. Okay, because the child is not gaining weight. Next, continue.
So history of presenting illness, the parents observed that their child was not gaining weight in comparison to the peer group. So child was evaluated in the private hospital and was put on anti-tuberculosis treatment in view of MONTO positivity. After 30 days of ATT usage, child now presented with vomitings and yellowish discoloration of eyes. And the mother observed that the child has been passing urine more often and excessive thirst since past 10 days. Vomitings since 5 days, non-bilious, non-projectile with food as content, not associated with blood. Yellowish discoloration of eyes since 5 days. There is history of constipation present. There is no history of fever, pain abdomen, blue stools, clay colored stools. There is no history of crying during micturition, hematuria. There is no history of cold, cough, increased work of breathing or recurrent respiratory tract infections. There is no history of cyanosis. There is no history of seizures, no history of feeding difficulties or bleeding manifestations or previous history of blood transfusions. There is no history suggestive of nutritional deficiency. There is no history of TB contact. Past history, there is no similar complaints in the past. There is no history of previous hospital admissions. Child born to third degree consanguineous marriage, third in birth order. Birth history, antenatally, there is history of maternal polyhydramnios. Term gestation with normal vaginal delivery. Birth weight is 3 kgs and cried immediately after birth. Developmentally, there is mild speech delay with developmental quotient of 85%. Immunization history, immunized as per National Immunization Schedule, and BCG scar was present. Dietary history, there is a deficit of 200 kilocalories and proteins 1.6 grams deficit is there. Socioeconomic history, a child belongs to lower middle class family according to modified Kuppaswamy classification. In the general examination, the child is conscious, irritable, and thin-built. Icterus is present at admission. There is no pallor, cyanosis, clubbing, koilonychia, lymphadenopathy, edema. Head-to-toe examination, the hair is normal, oral cavity is normal, no ulcers, skin and nails appear to be normal. There are no neurocutaneous markers. There are no signs of vitamin deficiency. Genitalia and spine are normal. There are no signs of dehydration. Vital data, temperature is normal, pulse rate is 1 or 2 per minute, regular, good volume, normal character. All peripheral pulses felt. There is no radioradial or radiofemoral delay present. Respiratory rate is 28 per minute and blood pressure is 80 by 50, which is falling in normal. Anthropometry, child length is 72 centimeters. Less than 3 standard deviation, weight is 5.47 kgs. Less than first centile, head circumference 43 centimeters, less than third centile, mid upper arm circumference.
What will be the previous centiles? Do you have any record of this thing?
Yes, sir, we have, sir. Here the growth chart, weight for age is plotted of the child at various intervals. Sir. We can see all the time the child's growth is less than third centile only. Only this records we could get, sir.
Okay.
Systemic exam.
Only weight is affected, length is not affected.
Yes, sir, both are affected, sir. We got only this statistics, like this records from the patient. Systemic examination, gastrointestinal system is normal. There is no organomegaly. Respiratory system, cardiovascular system, and CNS is normal. The summary is 2-year girl born out of third degree consanguineous marriage, brought with complaint of not gaining weight since birth, vomiting since 5 days, yellowish discoloration of eyes since 5 days, with history of polyuria, constipation is present, history of ATT intake for last 40 days. There is history of maternal polyhydramnios, and there is history of mild speech delay. On examination, there is icterus at the time of admission. Failure to thrive is present. There is microcephaly and with no organomegaly. So with this history of failure to thrive, with the renal complaints, we thought to evaluate for the tubular disorders like renal tubular acidosis, Bartter syndrome, and Gentleman syndrome. These were our differential diagnosis. So we went on with the basic investigations like complete hemogram, which is normal, hemoglobin of 11.9 gram per deciliter, WBC 10,500, and platelets of 4.6. CRP was negative. ESR in the first hour is 2 mm. Blood sugars were normal. LFT at the time of presentation, total serum bilirubin was 3.3, with the SGOT and SGPT were elevated more than 4 times. And initially, subsequently, after stopping ATT, the liver function test has normalized, and the renal function tests are normal. Serum electrolytes, we could see hyponatremia, hypokalemia, and hypochloremia with normal serum calcium. Serum phosphate and magnesium were normal. Chest X-ray was normal. HI was not reactive. In view of failure to thrive with the polyuria, we thought the renal loss of potassium is there. So we have done ABG and urinary electrolytes. In ABG, it showed metabolic alkalosis, and urinary electrolytes has showed increased loss of urinary sodium, urinary potassium, and urinary chloride. And the urinary calcium creatinine ratio was 0.11, that is less than 0.2. CUE was normal, thyroid profile was normal. Ultrasound abdomen was done to look for any evidence of nephrocalcinosis, which was normal study. Fundus and hearing were normal. Serum renin and aldosterone levels were also done, which are elevated. And genetic analysis was sent and the report awaited, sir. Here the provisional diagnosis is failure to thrive with salt wasting nephropathy with a metabolic alkalosis with hypokalemic hypochloremia. Most likely it is fitting in Bartter syndrome type 3s. Here we have a case series of Bartter syndrome presented at Nilofer Hospital, sir. Most of the children are presented at less than 2 years of age. Most common complaints or most common kind of presentation is failure to thrive, polyuria, polydipsia, dehydration, vomitings, diarrhea. The basic investigations were showing hypokalemia, hypochloremia, and metabolic alkalosis. So final diagnosis was for such presentation were Bartter syndrome. So successfully we started on indomethacin and we could see the improvements. Whenever a child comes with failure to thrive, in such case with the failure to thrive and polyuria, we thought the renal involvement was there. And with the basic investigation, we found that child is having hypokalemia and hypochloremia with metabolic alkalosis with the renal loss of potassium. Most likely diagnosis were Bartter syndrome or Gentleman syndrome, but the age group and the normal magnesium levels were more likely fitting into Bartter syndrome. So our final diagnosis was like Bartter syndromes. So Bartter syndrome is primarily a molecular defect in impaired salt or reabsorption in the thick ascending limb of loop of Henle that is causing renal tubular salt wasting and activation of renin-angiotensin system, causing hypokalemic, hypochloremic metabolic alkalosis. And there are 5 types of Bartter syndrome which are known. Mostly type 1, 2, and 4 are antenatal Bartter syndromes. And type 4, there is more likely association of sensory neural hearing loss that we have done in our case, which was normal. And in type 3, most likely the presentation is between 0 to 5 years. It classically presents with a failure to thrive. So the clinical features are, in our case, we have history of maternal polycythemia, history of consanguinity, suggestive of autosomal recessive disorder. Dysmorphic features will be present like triangular faces, protruding ears, large forehead, and failure to thrive will be there. Due to chronic hypokalemia, the child can have muscle cramps and weakness. Here there is normal blood pressure. So laboratory findings will be metabolic alkalosis, hypokalemia, hyperkalemia, normal serum magnesium, and hypercalcemia. The treatment part, mostly we have to prevent the child from dehydration. So adequate hydration has to be maintained. Maintain the nutritional status and correct the hypokalemia with a potassium supplement of 1 to 2 milliequivalents per kg per day. And the indomethacin has to be given. It's a prostaglandin inhibitor. And its dose is in infants is 1 mg per kg per day, and then 2 months it is 2 mg per kg per day. Final take-home points will be given by our guide, Dr. Srinivas Kalyani.
Thank you, Dr. Likita. Am I audible?
Yes, sir.
Yes, sir. Yes, sir.
Good afternoon, chairpersons, Dr. Soren sir, and good afternoon, everybody. Here we have a series of Bartter. Like one of the case in the peak summer pre-COVID was passing excessive urination while we were examining. A case of failure to passing HSV, we do screening blood sugar if it is normal. You do urine sugar that is normal. Very likely it is case of Bartter syndrome. Most of us do ABG when there is respiratory distress, but this particular case series of Bartter syndrome are missed because we don't do ABG regularly when there is no respiratory distress. So the take-home message is, number one, please let us say no to empirical ATT. This child was put on ATT for a trivial MON2 positive which was not documented. Then they have given a MON2 test, there was some local reaction. Some outside person had started ATT. For that, the baby was brought to us with drug-induced hepatotoxicity. So let us all pledge today to say that there is no empirical role for ATT. There should be a strong clinical evidence. Gone are the days of empirical ATT. So let us take the pledge, no empirical ATT. Number two, any case of failure to thrive, let us ask for history of polyuria. Simple. You go for electrolytes. If there is hypokalemia, hypochloremia, and go for ABG even if there is no respiratory distress. Very straightforward diagnosis is metabolic with metabolic alkalosis, hypokalemia, hypochloremia. We can make this fascinating diagnosis of Bartter syndrome. What attracts me to this is it is easily treatable. It is easily treatable with potassium supplements and very simple and very cheap drug like indomethacin, which often we forget. So the take-home message is we need to have a high index of suspicion for any case with the polyuria and failure to thrive and when there is no organomegaly. Early ABG, early electrolyte estimation will clinch the diagnosis of this rare diagnosis of Bartter syndrome, which is very easily treatable. These cost about 25 paisa each capsule. And we have salvaged about 5 cases like this. Thank you for this opportunity. I thank President Dr. Bhaskar sir, Dr. Venkateshwara Garu, Soren Chairperson for giving this opportunity. If there are doubts, we are here to clarify.
Sir, how many days indomethacin you are given, sir?
Yeah, these cases show a dramatic improvement within 7 days of indomethacin. Ideally, the potassium supplement, then indomethacin. They have to be for a long-term therapy under monitoring.
Okay, sir. Thank you. Thank you, sir. Wonderful case. Congratulations, sir.
Thank you, sir.
I would like to thank
you, Srinivas Kalyan, sir, the nice description of the case. Yeah.
Thank you, everybody. Thank
Same
you, Dr.
thing I also want to tell. This patient could have been confused due to the unusual treatment of the tuberculosis. ATT is confusing extremely. Yeah.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Soren, for your wonderful.
Okay, sir. Thank you.
And
thank you.
I thank
you.
all the presenters, especially from Shalini Hospital and Paramita Hospital and Nilofer Hospital and Apollo Hospital. Dr. Asad, Dr. Aparna, Dr. Likita, and Dr. Sneha. Thank you, everybody. Thank you, Doctor.
Yeah, thank you, one and all. And all the 4 cases were very interesting. And particularly the message given by Dr. Srinivas Kalyan is really very simple, straightforward. If it is there in our mind, probably it's easy to diagnose. Not uncommon disease, Bartter syndrome. All the cases were very, very interesting and useful, and they are all rare cases. They are not common cases. So that is the specialty of our Iaptcb clinical meeting idea. Thank you, Dr. Soren, for being with us since last 2 hours and patiently asking questions, taking clarifications from presenters. And I feel presenters are very lucky because it's an experience for them that's going to be very useful in their future examinations. So I sincerely thank all the presenters and their mentors, the institutes, the experts like Dr. Soren and Dr. Pritesh. My special thanks to Dr. K.V. Rao, who had conducted the program so well with his own questions and clarifications. Thank you. We'll see you again on 27th probably. We have a symposium on adolescent medicine. Luminaries are participating in that symposium. I request you all to join the symposium on 27th of this month. With these few words, I sincerely thank you all on behalf of IAP Twin Cities Branch Executive Board. Thank you very much.
Thank you, sir. Thank you.
Thank you. Thank you, sir.
Thank you, sir. Thank you very much.
Sir, shall I end the meeting, sir? Good, sir.
हो गया ना लीव करो मीटिंग को
First three cases. All are rare cases. Fourth one is part of it's very
Please,